Hello everyone and welcome back to my channel. So we have started the preparation for pediatric subject and we have covered a lot of topics, that is these are the topics that are done. Today we will be discussing the following topics, that is nutrition, Marasmus, Kwashiorkor and metabolic diseases, that is Phenylketonuria and Galactosemia, and rheumatic diseases, that is juvenile rheumatoid arthritis, Hinong purpura and malnutrition. So started from our first topic, that is nutrition, and in the nutrition we are having the important topic marasmus. So we are having a scenario that there is 1 year old infant who has weight of 5 kgs, head circumference and length are normal for his age. He has no dysmorphism but is just skin and bones. He is irritable and hungry. So what is the diagnosis, investigation and the complications? Another scenario is that there is a mother who brought her 1 year old daughter to OPD with complaints that she is ill for last 1 month, having diarrhea and low grade fever. Mother is pregnant again and she has stopped breastfeeding. Now she is giving her diluted cow's milk. Weight has not yet properly started. She is unvaccinated and center is far away from home and mother has to look after 3 kids. Father is labor. On examination, weight is 5.5 kg, moderately dehydrated with cold extremities, marked muscles wasting with loss of subcutaneous fat. She has distended abdomen with no edema fat. Another scenario is that there is a mother who brought 2 years old girl with complaints of excessive irritability. She was born at 36 weeks of gestation with weight 2 kg. She was exclusively breastfed till 1 year of age and then switched to cow's milk. Her weaning diet was also poor. On examination, she is vitally stable with poor growth parameters. She has severe pallor with soft systolic murmur of the grade 2/6. There is no hepatosplenomegaly. Okay, so from this scenario we got some points that there is the history of illness present, irritability present, muscle wasting present, and also she belonged to poor socio-economic status. Her weaning is poor and there is also soft systolic murmur of grade 2/6. So all these points indicate towards the diagnosis of marasmus, which is a nutrition disorder. So we have the definition of marasmus is that it is due to deficiency of proteins and calories. Diet is deficient in calories but no nutrients are entirely absent. Marasmus specifically proteins proteins and calories are deficient, but the overall diet is not deficient. So this is the deficiency of proteins and caloric diet. And the causes of marasmus are history of decrease or absent breastfeeding, feeding diluted milk formula, delay in introducing solid food in diet, and infections, that is diarrhea, measles, pertussis, and primary TB. These are the main causes of the marasmus. Then the clinical features are old man appearance, severe retardation, abdomen is shrunken, and muscle wasting is there. Remember, whenever there is a point written that there is muscle wasting, then you should know that it is indicated towards the marasmus. Severe retardation, abdomen is shrunken, and muscle wasting is present. Now we are having the Gomez classification for marasmus, that is weight is assessed at various ages by standard weight chart. If weight is less than expected for that age, then the child is considered malnourished. In Gomez classification, the weight of the baby is assessed at various ages by standard weight chart, and if the weight is less than expected for that age, then the child is considered malnutrition. So first degree malnutrition is that if weight is 75 to 90% of the expected weight. Second degree malnutrition is if weight is 60 to 75% of the expected weight. Third degree malnutrition is if weight is below 60% of the expected weight. Now the risk factors of marasmus are not having enough nutrition, consuming wrong nutrients, and absorption problems. The complications for marasmus are electrolyte abnormalities, risk of developing refeeding syndrome, cardiac failure and arrhythmias, UTI, sepsis and overwhelming infections, gastrointestinal malabsorption, hypothermia, endocrinological dysfunction. The management options for marasmus are detection and treatment of the early malnutrition, promote breastfeeding up to the age of 1 to 2 years, avoid artificial feeding till age of 4 to 6 months, introduce semi-solids at 4 to 6 months of age, immunization and primary care, and the prevention of infective diarrhea, for example, hand washing. These are the preventive measures and some management for the case of marasmus. So we have discussed the first nutrition disorder, that is marasmus, in which the main diagnostic point is muscle wasting, irritability, hungry skin and bones wasting, and there is poor socioeconomic status, poor feeding, and no breastfeed. So this is marasmus. We have discussed the definition, then the causes, the clinical features, then the Gomez classification, which contain of the first, second, and third degree marasmus. And then we have discussed the risk factors and the complications and management. Now coming towards the Kwashiorkor, we are having a scenario that there is our parents that brought their 2-year-old daughter with complaints of lethargy and anorexia. On examination, she is anemic, and with she is having moon face and edema feet. Her extremities are cold and dry. Another scenario is that there is 18 months old infant, has weighed 6 kg. She has anorexia, anemia, apathic face and edema feet. She has dry colorless hair and depigmented skin. Now these points are referring towards the Kwashiorkor. Whenever there is patient who is having anemia, who is having apathic face, and who is having dry and cold extremities, so this refers towards the Kwashiorkor. Now let's discuss the definition of Kwashiorkor. We are having that the develops in children whose diets are deficient of proteins. Now we have discussed that the marasmus occur when there is protein and calories malnutrition. In the Kwashiorkor, there is only protein deficiency. The complications are hypothermia, vitamin A deficiency, hypoglycemia, severe anemia, cardiac failure, infections, and dermatosis. These are the complications of Kwashiorkor. Now, the causes of Kwashiorkor are low protein intake, extreme scarcity of the food, low level of education, that is, people who do not know how to eat proper diet. Then the specific treatment for Kwashiorkor are more calories, more proteins, especially if treatment is started early. Then first calorie in the form of carbohydrate and sugars and fats. The management of malnutrition is initial treatment, rehabilitation, and follow-up. The emergency treatments is for first phase is fluid and electrolyte balance, hypoglycemia, control of the infection, hypothermia, dietary management, and the rehabilitation is recovery, principles of the management, and criteria for transfer to nutritional rehabilitation. So we have discussed the Kwashiorkor. We have discussed the specific diagnostic points, that there will be anemia, apathic face, and dry and cold extremities. Then we have discussed the definition, that it is the specific deficiency of the proteins. Then we have discussed the complications, that is hypothermia, hypoglycemia, cardiac failure, infections, vitamin A deficiency, severe anemia, and dermatosis is present. The causes is low protein intake and extreme scarcity of food and low level of education. Then we have discussed the specific treatment, the management of the malnutrition, the emergency treatment, and the rehabilitation. Now coming towards the next unit, that is metabolic diseases. We have the first topic, that is phenylketonuria. Now there is a scenario that an Asian couple with dark complexion give birth to a baby girl with very fair skin, blonde hair, and blue eyes. After a few days, baby develop mouse disorder order from her skin and urine and fits, which were generalized. Okay, this is the scenario. So there is a couple who give birth to a child. First she is fine, then she develop mousy odor from her skin and urine and fits, which were frequent and generalized. So we are having a definition that phenylketonuria is a genetic disorder which is characterized by an inability of the body to utilize essential amino acids, phenylalanine, and phenylalanine hydroxylase is deficient. Okay, what happens in the phenylketonuria, that the body is unable to utilize the essential amino acids phenylalanine. Okay, so and this is a genetic disorder, and the phenylalanine utilization is due to the decreased phenylalanine hydroxylase enzyme. Okay, now the causes are both the typical causes and atypical causes. The typical causes are mutations in the gene that helps make an enzyme called phenylalanine hydroxylase, and the deficiency of tetrahydrobiopter cofactor of the phenylalanine hydroxylation. If the deficiency of these enzyme occur, then this is atypical. If the mutations in gene that helps make an enzyme called phenylalanine hydroxylase occur, then it is typical phenylketonuria. Now, what questions are asked from the patient of the phenylketonuria? Without treatment, phenylketonuria can damage brain and nervous system, which can lead to learning disabilities. Passed down through families, baby must go phenylketonuria gene from both parents. Father and mother may not have phenylketonuria or even know that phenylketonuria runs in their family. So whenever a patient comes to you of phenylketonuria, then you should ask the history from the parents, that if this disability is present in his past family members, etc. The investigation options are Guthrie, also called PKU test, is a diagnostic tool to test infants for phenylketonuria a few days after birth. Okay, this is a test which is done in which the babies are tested for the phenylketonuria after the birth. The screening test of blood is done, then the urine ferric chloride test is done for the diagnosis. Clinically, usually normal blue eyes, fair skin compared to other family members. How can you suspect a case of phenylketonuria when a baby is born and his skin is fair and eyes are blue compared to other family members? So this is phenylketonuria. The early symptoms are vomiting, irritability, eczema like rash, and mousy odor to the urine. These are the symptoms. And CNS problem may be present. There is seizures, microcephaly, prominent cheek, and upper jaw bone. These are the CNS problems in phenylketonuria. Now, the prevention for phenylketonuria are: maintain blood level of the phenylalanine between 2 and 10 mg per dl. Some phenylalanine required for normal growth. Diet that required some phenylalanine, high protein foods such as meat, fish, poultry, eggs, etc., cheese, milk, major amount of starches and cereals. Phenylalanine free formulas should be used. Lifelong dietary restriction of the phenylalanine is done. Okay. So this is the prevention for the defect of phenylalanine. So we have discussed the metabolic disease, that is phenylketonuria, which is a genetic disease and which is by birth, in which the mousy odor occur, and the mousy odor from the skin and the urine occur, and there are frequent and generalized fits. So there are both the typical and atypical causes. The typical cause is mutation in the gene, and the atypical cause is the deficiency of the tetrahydrobiopterin enzyme cofactor. Okay, then we have to ask the questions from the parents about the family history. As it is a genetic problem, then we will investigate. First of test is Guthrie, then screening test, then urine ferric chloride test, then we will diagnose the clinically, that is the patient will be having blue eyes, fair skin compared to the other family, and early symptoms are vomiting, irritability, eczema like rash, and mousy odor to the urine. CNS problems may be there, that is seizures, microcephaly, and prominent cheek. And the prevention can be done by maintaining the blood level of phenylalanine between 2 to 10 mg per dl. Some phenylalanine required for normal growth, and the diet that requires some phenylalanine, high protein foods such as meat, fish, poultry, eggs, cheese, milk, major amount of the starches and cereals. Phenylalanine free formulas are used, and lifelong dietary restrictions of the phenylalanine is done. Now moving towards the next metabolic disorder, that is Galactosemia. Now we are having a scenario that there is a 9-month-old infant who has joined us, hepatomegaly and ascites. She is malnourished and irritable and has contact in both eyes. She is breastfed and also takes fresh cow milk. Okay, this is 9 months old infant with jaundice, hepatomegaly and ascites. She is malnourished and irritable and has contact in both eyes. Then she is breastfed and also takes fresh cow milk. His first cousin also has problem and died at age of 2 years. So this is a genetic problem. Another scenario is that there is a 3-month-old baby brought to ER department with history of vomiting for the last few days. He is breastfed and has similar episodes since birth. On examination, he is severely dehydrated and wasted. There is history of 2 days in the neonatal period in his family. So what happened? Galactosemia is inability of the body to use or metabolize the simple sugar galactose, causing accumulation of galactose 1 phosphate in the body, which causes damage to the liver, the central nervous system, and other body system. So what is galactosemia? It is a disorder in which the body is unable to metabolize the simple sugar. As a result, the accumulation of galactose 1 phosphate in the body occur, which cause damage to the liver, to the central nervous system, and to the other body parts. Okay, so we are having here the history that 3-month-old baby brought to ER with history of vomiting for the last few days. He is breastfed and has similar episodes since birth. On examination, he is severely dehydrated and wasted, and there is history of two deaths. So, if there is a diagnostic point that there is death of two babies in his family, and now this baby is vomiting and dehydrated, and he is breastfeeding, so we will get to know that this is galactosemia, as the patient cannot metabolize the simple sugar. Now, the causes are inheritance of the enzymes, three forms of disease: deficiency of the galactose and the deficiency of galactose 6 phosphate. Deficiency of galactose 1 phosphate uridyl transferase deficiency. Okay, so the genetic background of this disease is that there is the deficiency of the enzyme galactose 1 phosphate. Okay, so due to the deficiency of this enzyme, they cannot metabolize the simple sugars. As a result, the accumulation of glucose occurs, and it leads to defect on liver and nervous system. The clinical features are jaundice. Jaundice occurs due to this defect, vomiting and poor feeding, poor weight gain, lethargy, irritability, and etc. So the investigation options for this defect are prenatal diagnosis by direct measurement of the enzyme, then urine test is done to presence of the reducing substance and presence of ketone in urine, and activity of enzyme in blood test and blood culture for bacterial infection. These are the tests which are done for diagnosis and investigation. That is, the first diagnosis is by the direct measurement of the enzyme, then urine test is done for presence of reducing substances, then presence of the ketones in urine will be there, activity of enzymes in blood tests is checked, and blood culture is done for the bacterial infection. The treatment options for galactosemia are avoiding milk and milk containing products, infant fed with soya formula or other lactase free formula, and avoid milk for life, calcium supplements, and avoid dairy products. Okay, so the patient cannot metabolize the simple glucose, so the breast fed or breast milk is not given to the patient, and milk is avoided for life, and calcium supplements and dairy products are also avoided, and calcium supplements are given to replace that caloric need. The complications of galactosemia are cataracts, cirrhosis, severe infections with bacteria E. coli, and delays speech development, some mental retardation, irregular menstrual cycles, decrease the function of ovary leading to ovarian failure, tremors and uncontrolled motor functions, and death. These are the complications that occur due to the galactosemia. Then the statistics of galactosemia is that annual incidence of the classic galactosemia is estimated to be between 1 by 40,000 and 1 by 60,000 in Western countries. The mode of inheritance of this disorder is the classic galactosemia, and clinical variant galactosemia are inherited in autosomal recessive manner. Couples who have had one affected child have a 25% chance of having an affected child in each subsequent pregnancy. So this is the mode of inheritance of this disorder. So we have discussed the topic galactosemia, and we have discussed that there is a patient who is okay, who is having jaundice, hepatomegaly, ascites, and is malnourished and irritable, and has contract in both eyes, cataract, I think, and she is breastfed and also takes fresh cow's milk. So her first cousin died because of the same problem. Now we have discussed the definition of the galactosemia, then what are the different causes of the galactosemia, and how we will manage or treat the patient of the galactosemia. In the next video, we will be discussing the rheumatoid diseases, and okay, we have discussed the complications, the statistics of galactosemia, and the mode of inheritance of this disorder. In the next video, we will be discussing the rheumatic diseases, that is juvenile idiopathic arthritis and henoch-Schönlein purpuri.